From Microbe TV, this is Infectious Disease Puscast, episode 74, recorded on Wednesday, February 12th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I guess the typical banter right now is whether or not you watch the Super Bowl.
Is that what you're going with, Sara?
Yeah.
That's what
I was on
docs
service,
are
so
about.
that's the level of banter I'm at.
Okay. That's not what, the doom and gloom that the science community that I hang up. But I that's a better band. Were you an Eagles fan?
I was neither. Mostly watching for the halftime show this year. Well, I thought about saying, like, in this episode or the prior ones, having like a moment of silence for the fact that we haven't had MMWR, and we did technically get some releases, but it's like 2 articles, which yeah,
that was the first time in decades, right, that the MMWR did not come out. It's kind of crazy. But we live in interesting times. So we'll I don't know if we can go on, right, if we don't have any infectious disease literature to discuss. Not doing any research or anything. So we'll just have to see how that impacts our show.
Yeah. Wow. Well, let's talk about something more more fun. So Buzzcast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. So we're going to start with our viral section. And remember to listen to TWEV, This Week in Virology, the deep dives and the clinical updates. So the article, Global Impact of Mass Vaccination Campaigns on Circulating Type 2 Vaccine-Derived Polio Virus Outbreaks, an Interrupted Time series. Now, I discussed this also on a deep dive, so you can, if you want to hear Vincent Racaniello jumping in and making some comments. But the reason I did that is I feel like this is an important topic. So really what they're looking at here is there's this novel oral polio vaccine. And there's this whole idea that this is going to be so much better. Unfortunately, we've seen over 3,000 cases of vaccine-derived poliomyelitis since we've started doing the oral polio vaccine. And what they're really doing here is they're comparing the impact of this novel or oral polio vaccine to the monovalent, the original oral polio vaccine, the Sabin vaccine. And they're looking at when you jump in with what they call supplemental immunization activities, SIAs. And they compared which one's better. They looked at 37 countries, and unfortunately, what they're seeing is that they did not really see any significant difference to the novel oral polio virus vaccination to the original. The only place where they saw any kind of an improvement was maybe in the Democratic Republic of the Congo, if you can ever trust any data that you get from there. So not a great, and really just more, if you've listened to us on the deep dives, more reason why we're really pushing for the world to switch over to the injectable polio vaccine, the Salk vaccine, the vaccine we use here in the U.S. Really more evidence that it's not great to just keep putting this oral polio out there, because it does. It reverts to virulent, and then you end up with paralyzed kids. All right. I think I've monopolized the viral section here, Sara. The article, Co-Infection of SARS-CoV-2 and Influenza A/B among Patients with COVID-19, a Systematic Review and Meta-Analysis, published in BMC Infectious Diseases. a really interesting story. I remember that first year when, we get hit with SARS-CoV-2. We switch all our machines over. We stop doing any testing for influenza, and I was not surprised. But apparently, if you do not do an influenza test, it won't come back positive. People seemed shocked. They published on that, the fact that there were no co-infections. Well, nobody was looking. Well, what happens when you look? These are the results of a meta-analysis that included 38 primary studies investigating co-infection of SARS-CoV-2 with influenza in confirmed case of COVID-19. And the analysis found that the prevalence of influenza in co-infected patients at 95% confidence intervals was 14%. And you get the forest plots. Basically, you can see if influenza A is co-circulating, you're going to end up with a high percent. But no, getting the flu does not protect you from COVID. Getting COVID does not protect you from the flu. And it's important to look for both because you can treat both at the same time. And does that make a difference, right? That Tamiflu, that oseltamivir, is it really worth doing? Well, there aren't that many things in medicine where we can claim that there's actually a mortality benefit. And here we have the article, oseltamivir reduces 30-day mortality in older adults with influenza. And here we're actually seeing that, yes, it does actually reduce mortality. All right, we've also got pooled analysis from the 2019 Serious Outcomes Surveillance Network of Canadian Immunization Research Network, CERN, published in Open Forum Infectious Disease. Among 8,135 influenza patients studied, 2,126 did not receive antiviral treatment, whereas 6,009 were treated with oseltamivir. Oseltamivir recipients had an 18% lower risk of 30-day mortality. Didn't do much for influenza B. And key point here, oseltamivir remained effective even when initiated after 48 hours. And the influenza vaccination did not mediate the effectiveness of oseltamivir in reducing mortality. So, just to reinforce, I think we've done this before, when that patient shows up in the hospital, you want to get going on that Tamiflu. All right, I'm going right into bacterial. Oh my gosh. Well, I guess I get to give the plug for TWIM. Be sure to listen to This Week in Microbiology. I was listening to those folks today while I was driving about. Great recent discussion of biofilms and phages and Vibrio. And probably got you, with just the discussion of biofilms. But okay, so keep listening to us. You can go to TWIM afterwards. All right, the article, Predicting Benefit from Adjuvant Therapy with Corticosteroids in Community-Acquired Pneumonia, a data-driven analysis of randomized trials, published in The Lancet Respiratory Medicine. So these are results of a meta-analysis that included RCTs published before January 1st, 2024, comparing adjuvant treatment with corticosteroids versus placebo in patients hospitalized with community-acquired pneumonia. Primary endpoint, 30-day all-cause mortality, collected across all trials, and analysis followed the intention to treat principle. They analyzed heterogeneity of treatment effect using risk and effect modeling. The risk modeling, patients were classified as having less severe or severe community-acquired pneumonia based on the Pneumonia Severity Index, PSI. Fortunately, as you're going to find out, we don't need to learn about that. It doesn't matter. So for effect modeling, they trained a corticosteroid effect model on 6 trials, externally validated it using data from 2 of the trials, and the model classified patients into 2 groups, no predicted benefit and predicted benefit from treatment with steroids. They included RCTs, 3,224 patients across all 8 trials. 7.6% of patients died within 30 days. This amounted to 6.6% in the steroid group and 8.7% in the placebo group, giving us an odds ratio of 0.72, right? So we're seeing an absolute benefit of maybe 1 or 2%, maybe about 2%. We're seeing a relative benefit, 28% reduction here, 28% reduction. So they say, there's really a lot of variability here. There's heterogeneity of treatment effect. They try to sort out whether everyone benefits from steroids or maybe certain patients. Now, the corticosteroid effect selected CRP, and that's where we showed significant heterogeneity of treatment effect. In the trials where they separated this out, we're looking at 11.4% versus 13.1%. Among patients predicted to have no benefit, and these are really low CRP, no significant effect was observed. Whereas for those with predicted benefit, 13% died in the placebo group compared to 6.1% in the steroid group. Right? So using CRP to identify a particular group, we're seeing a 57% reduction. But remember, I was saying you don't have to worry about severe versus non-severe. No significant heterogeneity of treatment effect was found between less severe and severe. Now, corticosteroid therapy significantly increased hyperglycemia risk. This was actually one that really sort of threw me. Hospital readmission was 3.7% in placebo, 7% in the steroid group. So it doubled the risk of someone being readmitted. Unfortunately, I will comment, this is not open access. But Sarah, what do you think? I mean, corticosteroids, is it prime time? Are they using this where you practice?
I don't feel like I've seen it used for most people, at least recently. I'm just thinking through like the last couple patients I've seen recently.
If you read Up to Date, they say, we don't recommend it, and since everyone at Up to Date runs the world, right? We bow to whoever writes those sections. But it really is interesting here could you sort of risk stratify the people with these, significant inflammatory elevated CRPs, and maybe we should be thinking about whether or not we target them. But
yeah. And I think there might have been another publication that was in these last couple of weeks that was related to steroids that I think I had set it aside and must not have gone back to. But I did grab what I thought was a great read that was from CID, Rethinking Antibiotic Prophylaxis for Spontaneous Bacterial Peritonitis, SBP, in Patients with Cirrhosis. First, do no harm. So SBP, antibiotic prophylaxis, it sounds like has really been recommended since the 90s, give or take. And so the authors described the seminal study that it's really kind of based on. It had 80 patients, and this is what's kind of been used to support secondary prophylaxis for SBP. So these patients received norfloxacin, 400 milligrams daily, and were evaluated for SBP recurrence at 6 and 12 months. There was a statistically significant reduction in the recurrence of SBP, but it was underpowered to detect a difference in mortality, and there actually was no reduction in the total incidence of infections. But it was so widely accepted that there have not really been subsequent RCTs published that really exclusively look at that question of effectiveness of secondary prophylaxis versus placebo for preventing SBP. And so I didn't really know about that. And then I also learned that there was a 2020 Cochrane review that actually excluded that study that most of this is based on, and no mortality benefit was identified, regardless of whether you were using antibiotics for primary or secondary prophylaxis. So the authors outlined some of the potential harms, which I don't really need to emphasize very much with an ID audience, worsening MDRO colonization on long-term fluoroquinolones, side effects, C. diff, gut flora disruption. The authors argue for discouraging and individualizing the decision to provide SBP prophylaxis, whether that is primary or secondary, and, thinking about working on local consensus guidance with your colleagues. And they have in Table 1 some suggested modifications for the current kind of published consensus guidance. So I thought this was a really great resource and an overview of what is pretty weak supporting evidence. And I think we've all been in situations where you weren't really sure of the utility of staying on that SBP prophylaxis for very, very long periods of time. So I really enjoyed this paper.
Yeah, I'm trying to think, oh my gosh, really 6 to 12 months of taking a fluoroquinolone every day? That
Yeah.
doesn't seem like a good idea. Okay. The article determining the optimal antibiotic duration for skin and soft tissue infections was published in Current Opinions in Infectious Disease. And here the authors start by pointing out that few patients receive guideline concordant empiric antibiotics at appropriate duration in the United States. This is not limited to, but includes skin and soft tissue infections. So basically, we're just messing up all over the place. One of the most commonly identified opportunities to improve antibiotic stewardship is to stop with this duration. You ready for this? With this duration of therapy for more than 10 days. Where is that going on? People are treating cellulitis for more than 10 days. They point out that there is no benefit to longer antibiotic durations for SSTIs. I had to look that up. Skin and soft tissue. No, I didn't have to look that up. Skin and soft tissue infections in patients with obesity, right? Oh, you're carrying a little extra weight. We'll give you a few weeks of antibiotics. And it appears that longer antibiotic therapy, are you ready for this, is actually associated with treatment failure. In diabetic foot infections, those DFOs, opposed to the UFOs, 2 randomized studies suggest that in the presence of osteomyelitis, the total duration of antibiotic therapy for patients treated non-surgically does not need to be more than 6 weeks. Those of you out there doing 8 or 12. In a prospective randomized non-inferiority pilot trial, patients with DFO, diabetic foot infections, who underwent surgical treatment and received either a 3-week or a 6-week course of antibiotics. You ready for this? Similar outcomes and antibiotic-related adverse events. In patients with necrotizing soft tissue infections, successive observational studies clearly suggest that short duration of antibiotics after source control, well tolerated and just as effective as those longer courses. And so everyone can read and benefit from this great article. It is not open access. Okay.
I'm struggling. I haven't gotten my library login yet, so pretty much
no,
all the
let me know.
articles.
I'm always happy to help.
No, I know, but I've been much more cognizant of the ones that are not open access.
It's terrible, right? Like here's where they're basically saying
so
like this
much.
is harmful. We're giving all these people necessary antibiotics. This could really improve things. But yeah, unless you're going to ante up, you're not going to be able to see this.
So I love Kingella. I actually don't think I've ever talked about it on Puscast. Maybe I have. But that's what prompted me to grab this paper, which is from CID, The Stealth and Potentially Fatal Nature of Kingella, King Outbreaks in Daycare Facilities. Here, Dr. Yakubski, who's an expert in Kingella, I feel like his name is on like every publication, gives an overview of the organism, which is a very important bug in bone and joint infections, particularly for children 6 months to 2 years old. And he reviews 27 outbreaks of invasive Kingella disease, which included both published outbreaks and it sounds like some personal communications. But these were usually daycare kiddos with a median age of about 14 months. The attack rate in affected classrooms had a median of 15.5%. 92% of affected children in outbreaks had some sort of skeletal system involvement. And so the use of NAT has really increased how often we identify Kingella. And in about half of these outbreaks, diagnosis was generally confirmed with some sort of species-specific NAT. It was also pointed out that many of the outbreaks were detected by people who were sort of actively involved in studying Kingella. And I think there's a little bit of attributing some of this identification to people who were aware and looking for the pathogen. He also points that this is largely reported in facilities in Western countries. I think this is probably a reflection of the inability to have some of these blood culture systems and NATs in certain locations rather than a unique distribution in these countries where the outbreaks were reported. But lastly, 3 children of the I don't even think I said, I think there were about 70 something children. 3 did have serious infections, including a complicated endocarditis case. There were 2 deaths. And so one of the questions is, if you were in a setting where you had a single case or multiple cases of Kingella in a daycare, do you use prophylactic antibiotics? Do you give them to asymptomatic kids? Do you give it to kids that are, quote, at risk? How do you identify that? So it's just one of the few things that can cause a bone and joint infection that you could get in an outbreak, which I just think is fascinating. So anyways, if people want to learn more about Kingella, you can read this.
All right. An article from the King of Kingella. Right on the spot, I did that. Okay, the article, Piperacillin tazobactam versus cefepime or carbapenems for the treatment of bloodstream infections due to bacteria producing chromosomal AMP-C beta-lactamase, a systematic review and meta-analysis published in the journal Infection. So, as you get from the title, results of a meta-analysis pooling risk ratios through random effects models in order to avoid the statistical sin of pseudo-replication. I was going to do like a little thing talking about random versus, fixed effects and the different effect models. But so they end up with 20 studies, one RCT, one case control study, 18 cohort studies included in the analysis for a total of 2,834 patients when comparing piperacillin tazobactam with alternative treatments, cefepime or carbapenems. No significant difference in mortality rate was observed between the treatment groups, while a higher rate of microbiological failure and clinical failure was observed among patients receiving piperacillin tazobactam. No difference was observed in microbiological and clinical failure rate among patients treated with cefepime or carbapenems. Actually, a lower mortality rate in those receiving cefepime with a relative risk of 0.74, p-value of 0.014. Right, so we always have this whole idea, right? The carbapenems are like super powerful and the big gun and, the top shelf antibiotics. So the challenge is that AMP-C producing Enterobacterialis therapy is that carbapenems are commonly regarded as the first-line therapy to treat these infections. Unfortunately, most studies investigating the role of piperacillin tazobactam or cefepime for the treatment of AMP-C producing bacteria have this observational design, generally with a small sample size, and have inconsistencies regarding the use of combination therapy, durations of treatment, source of infection, and source control measures. So we really need RCTs to sort out really what is the best treatment here. We don't want to fall into this trap of pseudo-replication and using the wrong models to analyze this stuff.
Great. I have a paper from JID, is systemic dissemination of BCG following neonatal vaccination required for protection against Mycobacterium tuberculosis. So in some preclinical studies, adults who received IV administration of BCG had improved protection against TB, which led authors to hypothesize that the neonatal intradermal BCG administration likely leads to some sort of low-grade bacillemia, bacteremia in newborns, and that this systemic spread is what improves protection via something called early clearance. And that early clearance means the observation that the exposure to MTB doesn't lead to infection because that MTB is eradicated before the infection is ever established. So I think this is super cool, but they were just sharing ways that this hypothesis can be tested, such as assessing blood samples for BCG bacteremia following administration to newborns and looking at blood samples in different age groups. They also explain how those insights would lead to actionable outcomes. So thinking about the design of future TB vaccines based on that systemic dissemination, or thinking about the duration of that dissemination after the newborn intradermal administration, and if that duration of time is a correlate of protection. And then something else that I thought was interesting is less than half of newborns receive BCG within a month of age. So if we had data that said it may help, add an incentive to administer this vaccine earlier at birth to all eligible newborns, that would come from potentially data that says a delay reduces that propensity for systemic spread, which potentially would decrease the amount of protection that they have. So I think, really cool concept. And I always think BCG type articles are worth us bringing onto Puscast. So I picked that one out.
Yeah, I'm curious about this, right? I don't know if you've run into this much, but most places the kids are getting it, in that first so many months of life. But let's say you're like a State Department kid, or you moved to one of these areas. Sometimes they'll get it when they're like 2, 3 years old, and in those cases, the PPD will stay positive. Where if you get it right, month or two, within then, it's I think 98% will revert to negative by the time they get to their 20s. So I sort of wonder, like, do you want to maybe get it earlier, then maybe get another dose? Is there some sort of, is there any way to maximize what we've got with BCG? Because boy, it's been how many decades of working on future, TB vaccines without really getting where we want to be.
Yeah.
All right. That's me just musing. Risk of aortic aneurysm or dissection following use of fluoroquinolones, a retrospective multinational network cohort study. So keep this in your back pocket so the next time you're pimped on rounds, you can be like, well, this article published in eClinical Medicine, results of a retrospective cohort study conducted using a large distributed network analysis across 14 databases from 5 countries, United States, South Korea, Japan, Taiwan, and Australia, included 13,588,837 patients aged 35 or older who initiated systemic fluoroquinolones or comparable antibiotics for UTI treatment. They reported no difference in risk of aortic aneurysm or dissection between fluoroquinolones or Bactrim in this study. No significant difference in risk for fluoroquinolones versus CPH. So basically, when you get pimped, because this is one of those things, like they want you to talk about this risk. I don't know, maybe it's not really a thing.
Well, I will take us into our fungal section. We like to just plug that The Last of Us Season 2 is coming in April, so not too far away. The paper I have is from NPJ Vaccines, developing mRNA lipid nanoparticle vaccine effective for cryptococcosis in a murine model. The authors share an, as the title says, mRNA lipid nanoparticle LNP that encodes known cryptococcal antigens as a proof of principle evidence that this could protect against cryptococcal infection, or they called them mCherry LNPs. So the CD1 or chitin deacetylase 1 cryptococcal antigen offered the best protection in mice models, which they used with challenging intranasally to the vaccinated mice. And then the CDA1/BLP4 subunit protein vaccine was highly effective after encapsulating in glucan particles. And so 80% of the mice immunized with these CDA1 LMP and capsule vaccines survived the entire study period. They also found that the lung fungal burden in the surviving mice was lower. So a possible cryptococcal vaccine, of course, very cool. So that's why I included it.
All right. I'm just waiting to think how people will look at this. More of this money wasted on vaccines for mice. The mice don't need vaccines. People need vaccines. Anyway, if you don't see the connection, don't worry. Those people are not listening to Puscast. All right. The article, the Araneopathogenic genus. You're going to pronounce all these words for me, Sarah. Glibellula, Corticosteraceae, Hippocreales in the British Isles, including a new zombie species on orb-weaving cave spiders, Metanae tetranathidae, was recently published in Fungal Systematics and Evolution. Like, that's what I stumble on. For background, our listeners may know about a Ophiocordyceps unilateralis, commonly known as zombie ant fungus, and maybe the inspiration of a great show. This is an insect pathogenic fungus discovered by the British naturalist Alfred Russel Wallace. Here, these investigators report on the occurrence of a novel species infecting cave-dwelling orb-weaving spiders of this subfamily Metanae Tetranethidae in the British Isles, the new species Gibellula attenboroughfae. Do you know who that's named after? Probably David Attenborough, right? Attenborough is described and illustrated, and its ecology is discussed, leading to the conclusion that infected spiders exhibit behavioral changes similar to those reported for zombie ants. Now, this is a really fun article, and I'm starting like, oh, really got to throw a lot of good photos. And they do lots of great photos. It's such a great discovery story. So we read that during the BBC Winter Watch television series in 2021, filmed on location in Northern Ireland, a fungal infected spider was identified on the ceiling of an abandoned gunpowder store and provisionally identified as G. pulchra. Images sent by the BBC to the senior author of this paper suggested that this was a novel species of the genus Glibellula, and that the reclusive cave spider host, subsequently identified as the orb-weaving spider, Metallina marinae, Tetranethidae araneae, had moved to an exposed situation before death, indicating a behavioral change for this usually reclusive spider. These suppositions were included and discussed in the following 2022 Spring Watch series, after which the specimen was removed and sent for identification. And they've got these great images, great photos. They've got that orb-weaving spider. It actually looks like right from The Last of Us, right? With this big fungal head. And
it's also pretty great that it's named after David Attenborough.
Yeah, definitely.
Yeah, the photos are pretty hot. I'm just picturing like looking up on a ceiling and seeing that. I'm not afraid of spiders, but that one would probably freak me out a little bit.
My introduction to David Attenborough was a video series, When Animals Attack, right? It's got like the orcas coming up on the beach, grabbing the seals, and he was tremendous.
Yeah. And then I think I'm wrapping up our fungal section. I pulled one paper from Medical Mycology, Sensitivity of Coccidioides Serologic Test Among Culture-Proven Coccidioidomycosis Patients with Hematologic Malignancy Compared to a Matched Immunocompetent Cohort. This was a retrospective study. They looked at, as you can guess from the title, patients with culture-proven cocci infection and compared the sensitivity of serology between a sort of combined heme malignancy hematopoietic stem cell transplant group versus an immunocompetent cohort. They found that patients in that heme malignancy group had statistically lower positive cocci serology test results, 37% for 72%. So just as like a good takeaway that serology is not reliable in this immunocompromised group, which is true for a variety of other things that we deal with in ID, but just remembering to pair that with the antigen and or, of course, empiric treatment if you were had the right epi exposure and you were really concerned.
Yeah, sort of like just the concept here. Let's ask this person with a broken immune system, if they're making antibodies against something, right? I mean, not surprising that we don't trust serology in someone who has trouble making, those antibodies. All right. I'm going to say a couple exciting articles here. We're trying to avoid using banned words, Sarah, in our discussions, right? So I don't know if, this will get flagged with the software, but the article, New WHO Guidelines for Treating Rhodiense Human African Trypanosomiasis, Expanded Indications for Fexinidazole and Pentamidine, recently published in the Lancet Infectious Diseases. We have a nice summary, so let me just go through a shortened version of this. WHO has revised its Rhodesiense Human African Trypanosoma Treatment Guidelines, so East African Sleeping Sickness. This review, maybe that's like better to say that, instead of immortalizing, that Rhodes guy. This review reports on the decision-making process and summarizes the new recommendations and their potential implications for healthcare professionals and policy makers. Fexinidazole replaces Suramin and Millarcipro as the first-line therapy in individuals aged 6 and older with a body weight of 20 kilograms or more. as fexinidazole is effective in both stages of East African sleeping sickness. You don't have to do that lumbar puncture because it's going to work in early, it's going to work in late CNS spread. In settings in which first choice drugs are not readily available, immediate interim treatment with pentamidine is suggested. They have this really nice flow chart. I won't, no spoilers, but there may have been a recent East African sleeping sickness case discussed on This Week in Parasitism. Just saying. All right. I don't know about you, Sarah, but I am still on speaking terms with the WHO. Announced 30 January 2025, WHO verifies Niger as the first country in the African region to eliminate onchocerciasis. So Niger joins 4 other countries that have been verified by WHO for eliminating onchocerciasis. River blindness, folks, all in the region of the Americas. Colombia was 2013, Ecuador was 2014, Guatemala 2016, Mexico 2015. I don't know why they did that out of order. And now Niger in 2025.
Yeah, I saw that. That's cool.
All right. And we're going to finish us off with a miscellaneous paper. The article, Telemedicine offers solutions for the rural disparities in infectious disease care delivery. It is a short read, and I think it's important, not just to ID docs, but really challenges facing our country as a whole. So this should be like out there, covered by the lay media. Is that what they call it? They point out the growing shortage of ID docs. And I should, sort of echo what they say here. This didn't just start to happen. You go back a decade, to about 2015, as they point out. In 2015, you already have only 50% of the training spots for infectious disease docs filling. A few references to studies that have demonstrated where having that infectious disease specialist, it's cost saving. It leads to better outcomes, less deaths, less inappropriate antibiotic use. Maybe they'll stop those antibiotics before 10 days in cellulitis. Less toxic unnecessary antibiotics, right? Where you end up with C. diff or renal failure. Shorter hospital stays. Listen, hospitals. Even avoiding some of those hospitalizations, which may not be that necessary. And they highlight that in rural areas, this shortage is the most significant. I think we've discussed 80% of counties in the United States do not have a single infectious disease doctor. And they suggest infectious disease telemedicine as part of the solution. But then I found this really hilarious, right? And I've seen this before. They're in their rough draft, they put in brackets, cite Seema and Linda's publication in OFA. And Seema and Linda are actually colleagues of theirs at UPitt. And I think didn't get put in. I was telling them this is much better than one time I saw a publication where left in brackets was cite so-and-so's crummy article because he might be a reviewer. And that made it into print, right? So I did email Christian Perez down at University of Pittsburgh, and they'll actually.
I think we talked about that paper on Puscast. I think I might have brought that paper on actually.
You did. It was back in November.
Yeah.
It was a great paper. So I've left the link into Seema and Linda's publication, as well as Christian Perez's publication here. So.
Awesome. Well, that brings us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do or just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders, parasiteswithoutborders.com, and just click on the donate button.
I'm Sara Dong. You can find me at Sarah Wynn Dong or Febrile Podcast on Blue Sky or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center, parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.